So this project is all about improving shared decision-making for surgery. I'll explain a little bit what it is, although I know that people on the call are experienced in PPI, so you probably know what it is already. And I just want to acknowledge that obviously, as with all other studies, this is a massive team effort. We've got collaborators in Bradford, as I've mentioned, and we've got collaborations in 3 hospitals, and without them, it wouldn't be possible. So I'm presenting this on behalf of a lot of other people. Righty, let's see if that works. So shared decision making, I mentioned that I will be explaining a little bit what it is. So it is a process where patients and healthcare professionals work together to agree on a treatment plan. So they're collaborating with each other rather than in the olden days where it was the approach that the doctor knows best and they diagnose you, they propose a treatment plan, they just tell you, oh, this is how it goes now. So shared decision making, we really are interested in having a conversation around what patients' preferences are, what their lifestyle is like, and what they value, so that treatment can align with these values. And similarly, it's really important to talk about treatment options here, because especially in surgery, it might not always be the best option for people. There's lots of different treatment alternatives, or perhaps even doing nothing. And for some people, in some cases, this might be the best option. But unfortunately, we know that good shared decision-making and optimal shared decision-making only occurs for about 1/3 of surgical patients. And this is really problematic because surgery is irreversible. Once you've had surgery, the consequences are quite drastic, and it basically can be a life-changing decision. So we know that people say they want to have more involvement in decisions about surgery, and they want to know more information and want to have those discussions with surgeons. So that's where the ALPACA study comes in. And I guess I need to caveat this because the ALPACA study is one of many studies that tries to improve shared decision-making. It's not a new concept. It's been part of the NHS long-term plan, and there's lots of good work going on in pockets of the NHS. So, you know, surgery is just one area, but obviously shared decision-making cuts across all of different disease areas. And we know that there is a lot of improvement that's been going on, but the problem is that those areas there's improvements in isolation. So small teams are doing great work, hospitals are doing great work, but we haven't found a way to roll out improvements at large scale. And that's really where the ALPACA study is quite unique. So our overall goal is that we want to improve shared decision-making for everyone offered surgery. So for every patient coming through the door of a hospital and offered surgery. And we mean that for everyone, regardless of their background. So anyone who's, you know, economically or socioeconomically deprived, who's got specific caring needs, who people who are from ethnic minority backgrounds, and so on and so forth. So how do we do this? So that's obviously the big the magic ingredient. So as I said, we're aiming at a large scale rollout, and really we can only do this if we have the technology available to us. So what we've done is the rollout of a new electronic system and an accompanying process with that before surgery happens, so that we can intervene when shared decision making hasn't gone so right, before the patient actually goes into surgery. And I'll be explaining a little bit more about this and the 3 key parts involved that make up this new process and the system. So the ALPACA study really is this 3-part intervention. So the 3 key processes that supports patients' decision-making. So let's assume we've got a surgical consultation at the start, and the patient talked to the surgeon and it's been booked for surgery. In the first instance, we send every patient booked for surgery an online survey to find out whether there were problems with shared decision making. And we do that in real time, meaning within 24 hours of the surgery booking, the patient gets sent an electronic survey that they can complete either via email or via SMS. Okay. In the second step, we feed back that information that we receive from those surveys to clinical teams so that they're aware of the problem. So again, once the patient's completed this survey online, we know that whether their experience with shared decision-making was good or bad, and we pass that on to the clinical team. And that's quite crucial because research has shown that feedback is prompting change in practice. But it's also important so that we know who has the problem and what the problem was, so that we can really tailor any interventions or any improvements. And that's the third step. So in the last step, and the one that is meant to address the problem, we haven't defined what exactly the sort of like remedial action is, but there's some sort of tailored activity, which can be an additional contact, or a phone call, or just, you know, some sort of activity that addresses the shared decision-making problem that was identified through step 1 and 2. And that can be, as said, another conversation where all of these things that make up shared decision-making actually get addressed, so that patients feel that they were listened to, that they've received all the information, that they talked about all the options, and then they go into surgery, or, as has happened before, they actually decide not to proceed with surgery. And obviously this is the I would say the core of ALPACA. But obviously there's lots of, you know, different contexts, different situations where that time period between consultation and surgery is obviously quite small. And we know that there is a lot of assumptions we're making about, you know, filling in the survey, giving feedback. So this is the ideal scenario. So just to sort of touch on the boundaries or the scope of the project. So we are looking at adult patients only, not pediatric patients, so no children. We're looking at all elective surgical procedures, so are excluding any emergency procedures where the time is so limited that we cannot intervene. And at the moment, we're looking at NHS hospitals only, so UK-based public sector. And important to know as well that this is only for patients with capacity to consent for medical treatments. It's a major drawback, but we know that those without capacity to consent need additional support, and there are just other processes in place in order to support them to reach true shared decision making. So for now, this is what we go with. And some good news to share. So I've said that we've been going since 2021, so we've got a lot to report. And we actually have found that a lot of patients receive and complete the survey, which is really good news because it's an unsolicited electronic survey. And I think when I look back at the literature, response rates are normally between or around 20%. So we've achieved 51%, which is really good. And as you can see as well, we've since 2021 have received 23,000, over 23,000 responses. So we've sent out just under 50,000 surveys. And I know that there are about 700 patients a month coming through the doors of the hospital in Bristol at the moment. So they're all receiving the survey. Then another good news, we are able to collect that information and analyze that information and give it to clinical teams. So we know that in Southmead Hospital, that there are only 2% of patients who actually say they've had a terrible experience with shared decision making based on the survey that we receive. And 65% report optimal experience, so score it highest. So that is a really good picture to paint for the clinical teams, because we know that not everyone is bad at shared decision making, but it's those 2% that we need to address. And I've been mentioning Southmead a lot, so that's where I currently get the data from, so I'm able to analyze it. But actually, we've managed to roll out ALPACA in 3 different trusts. So in Bristol in Southmead, and the BRI, so the University of Bristol Western Healthcare Foundation Trust. God, that's such a mouthful. The other hospital in Bristol, and Bradford as well. So we know that we can make it work in other hospitals, and we are currently writing a grant application for more money to roll it out to a lot more hospitals. But as with everything, there's more work to be done. So we still have got a lot of work to do in terms of actually proving that it's effective. So we're rolling out these processes in the hospital, but we haven't yet received the funding to actually show that we've improved shared decision making. So that's a really big project for the next years. And then where the big milestones that we want to achieve at the moment is, I mentioned that we want to improve it for everyone. So at the moment, we need to work out whether our intervention, those 3 steps that I mentioned, are actually works for everyone, including those groups that I mentioned. So the elderly who might be digitally excluded, people of poorer socioeconomic background, ethnic minority who might have problems understanding the survey and the language, or those with additional needs, and those with who've got carers or who need to work with carer support. So that is the big package of work that we've been investigating for the past, I would say, 9 months, and that we're currently funded to do by the NHR. And we specifically work with underserved groups and communities to ask them about, well, what is it about those 3 key ingredients of the ALPACA that may or may not work for you? And it is, it's been eye-opening. So far we've collected data from about 21 participants. I don't have time to go into detail to speak about the results here, but it's been really fascinating, and surprise, surprise, some of these steps don't work for everyone. So we need to make some adjustments to the intervention and to our program to be more inclusive. And yeah, just to sort of touch on our method. So we are conducting interviews, we're conducting focus groups, and we're going out to community events to try and recruit people and speak to people and collect data from these 3 areas. But we're being very flexible in terms of our data collection methods. And that was a quick snapshot of the ALPACA study. And before I go into this second part of the presentation, I will pause here quickly and try and stop sharing my screen. Great. Nice. It's nice to take a break from the slides. So I'll go back in and talk more about how we engaged and involved underserved groups, primarily for the purpose of what I just said, finding out more whether that process works for everyone. And I must say, I feel a bit like a fraud with this, because there are lots of people who have done such amazing work engaging communities, and we've mainly capitalized on other people's work. So I feel a little bit weird, like sitting here presenting on that. But I think there's some important things to say that are relevant for ALPACA, and perhaps for anyone or any other study that has got a similar setup. So at the first slide, I just wanted to set the scene a little bit, and why perhaps how we engaged with groups and what we've done is a little bit different to other studies. So starting with the broad study scope and broad target audience. So my reflection on this is it's incredibly difficult to engage underserved groups when we're looking at all patients with all diseases and conditions in all types of surgery. So it's really hard to pin down your lived experience because it could be anyone, which also means that there is the support, or the existing patient groups are usually the ones that bond over a certain common experience. So we can't just go to one group and take their experience. So we have to go broad. the other added difficulty is that we've got 2 locations, which is amazing. We've got Bristol and Bradford, and they were purposefully chosen to complement the socio-demographic makeout of the 2 cities. They're quite different. And I also want to acknowledge my fellow researcher Huma here, who's the researcher in Bradford. She's been doing amazing work there and soaking up the knowledge that Bradford's developed in citizen science and co-production. It's really great. And a lot of the information I share today is the information that she's given to me rather than my own experience. So, but that also makes it difficult that we've got those 2 locations that are quite dissimilar. Then I mentioned this before, so the purpose-driven PPIE versus relationship building, and I've put this on here because I know that there's been a real drive to have the long-term relationship building with community groups and you know, giving back to the community, going there repeatedly, having a real relationship of trust between researchers and community groups. But because ALPACA is so broad, it is very, very difficult because we haven't got a single group that we can draw on, because it's very varied. We need to spread ourselves thin. And as soon as we spread ourselves thin, we cannot have that in-depth engagement over a long period of time. So that's been really difficult. And at the end of the day, we're funded for 21 months and need to recruit people from underserved groups. So that's just my reflection on why I think it's really difficult. And I might have an unpopular opinion here that actually relationship building for us it doesn't work. Not at this stage, at least. Then we have been carefully planning our project and have actually built in 6 months of engagement before any study activity starts. And that was encouraged by the NIHR to do. So that was needed. It was desperately needed. And I can recommend it to anyone putting together research bids and grants that this is really absolutely necessary. And similarly with the resources, we've allowed probably 20% of our budget just for PPI activities, research and travel, translation, etc., etc. Which, yeah, it's probably not news to people, but just to say that this was really valuable. And diving into specific activities, we have got an absolutely fantastic patient advisory group. I think for me, probably this is the most important point when you want to engage with underserved groups. Although the group is mainly there for oversight and guidance, but they've been really integral to some of the PPI activities sort of inputting into activities, but also planning them, giving ideas for what to do. And that was made possible because they're from really diverse backgrounds. So Molly is here on the call, who's part of the PAG, and she has been for a long time. So the diversity is key. So we've got some people who have never been involved in ALPACA and some that have been for 3 years, some that live in Bradford, some in Bristol, some that have good shared decision-making experience, and some that have never heard of it. And completely varying interests and skill set, and that's been really key. And very keen to capitalize more on this, because I don't think in the past half a year we probably have used it enough. But just to highlight some of the importance of our PAG, because if you get the right people, they're really key gatekeepers to community organization and research partners, and putting you in touch with them. Again, nothing out of the ordinary, nothing new, but they can identify your participants and they know about the community and about the events. And I think for me, this for ALPACA was absolutely key. I've been involved in other PAGs that just haven't got that link to the community. And if I was to ever set up a PAG again, I would be, rigorously asking people like, how popular are you in your community? So yeah, that's just, again, a reflection of why this is so important. It will save you a lot of work because they're effectively team members. And they've helped us co-design materials and ideas for engagement dissemination across the 2 cities, Bristol and Bradford. And yeah, to drill down into more activities, we've just done a vast amount of engagement activities. And it's, again, this comes back to that we're spreading ourselves thin here for a lot of reasons, because we need the breadth to get to different experiences and different audiences. But I also found that for each engagement event we did, there were only ever like 1 or 2 participants that we recruited. So, which is, I guess, a good thing, because we get the spread, but also there is just also a limit to how interested people are in contributing, because it's also quite an abstract thing to be talking about shared decision making for surgery if you're not just at the moment in this process of going through surgery. So some of the highlights here. So we've exhibited at events, festivals, presented at research meetings, forums, done workshops and discussion session with community groups. Like this morning, I was at a dementia wellbeing event, which is held every month, and spoke to them about ALPACA. So it's like there's lots going on, and I was just like amazed by how much is actually going on in the 2 cities. And I just want to touch on again that there are so many organizations, as I've just said, that is completely overwhelming. When you get in touch with the right people, like suddenly it just spirals, and there's this like mind map of so many different organizations, and especially like when we're looking at all the underserved groups, so elderly and digitally excluded, economically deprived, there's like specific support organizations for all of these different groups, and it's just fantastic. And I think like I've only scratched the surface. So you probably recognize these groups here. Lovely Kat and her My Friday Coffee Morning. So we've visited them a couple of times. We've also been really lucky to receive the support of Affy Health in Bristol, who are obviously absolute champions in community engagement and health research promotion. But there's also some existing studies like Clarity that are very research focused, and these are the things, the groups in Bradford that we've capitalized on. So again, an existing cohort study that we tapped in to reach an elderly population. There's some PPI groups existing in Bradford, like the Better Start Community Research Advisory Group. Always a mouthful, these things. And so there's a lot. So this is only an example of that. We're really lucky to receive the support of the existing cohorts, where we didn't need to actually do a lot of relationship building ourselves. Then the majority of the work, particularly in Bradford, has been in community-based organizations. So in Bristol, obviously I'm the one doing the engagement work and the data collection. So there's been about 3 community organizations that I've engaged with, but again, it goes back to what I said before, like I've visited them once, I've not gone back, which is probably bad practice in what's being promoted at the moment. But equally, there's just a limit to what we can do in the time available. And some of the strategies that we use I was just there to observe sometimes, and I've just had informal discussions with the attendees or staff there, but it was enough to raise awareness about the study and recruit participants as well. So Huma in Bradford has done a lot more work around visiting community organizations. She goes to all of them repeatedly and some of them regularly. So she sometimes sits in one of the organizations on Tuesdays, just is there, has her lunch there, and tries to just speak to people and build that relationship. So she's done a lot more. She's also done presentations there when there's slots available, and different activities and informal discussions. So a lot of these can be just computer courses, English language courses, exercises. So she's tapped into all of these different courses that are being provided to support people from ethnic minority or economically deprived populations. And what's really crucial, similar to all the champions that we see in the communities, it's the staff based at these organizations have such a key gatekeeping role for us, that it's been almost it was almost too easy to get into these community organizations, because everyone's just so welcome. It's really fantastic, and they're so willing to help us out with recruitment. And then faith settings, so really important, specifically in Bradford, to visit mosques, gurdwaras, churches, and attend different activity sessions to promote study. Again, Huma has done a lot more of this. She's also got the advantage of speaking Urdu, Punjabi, and all of the languages that are really resonate with the population there. Whereas I went to the Gurdwara, which is the building with the brick stones in Bristol. It's only down the road from me, and I've been to temples before, and I love being there, but it felt very alien to me to be in that temple in the capacity of a researcher, because I feel it's so interesting to speak to people about their faith, about their beliefs, and it just felt super unnatural to then be talking about the study, and that I'm not here just as a person being interested in the religion or in their practices. So I've abandoned that quite quickly, just because I live locally as well, and I think it just felt really awkward. But that's probably where this relationship building comes in the long run, but that takes a lot of time. And this is a bit of a boring slide, to be honest, but I thought just to round things up for what my observations and reflections are. I mean, you probably have noticed that I've been, probably have some unpopular opinions about relationship building, but I think this is quite important to sort of just, for anyone who wants to conduct this research again, is that we found face-to-face and verbal communication is the way forward. Obviously, the printed flyers that we had, they just don't work for no one, and not even in a translated version, in our settings at least. That we had translations of animations and native language interviews. They were super effective, but of course only possible because Huma is a genius when it comes to languages. I can't do these, and important to note that participants often chose informal settings, so we obviously gave them the choice where they want to do interviews in focus groups. So they chose cafes, parks, their own homes, and the minority of the interviews were over the phone or video call, but that has implications because they're just not in a rush ever. So sometimes I know that Huma, she spent 3 hours talking to someone, because if you go to their home, you get offered tea, you get offered coffee, and you just have a lovely chat. And it just, again, you just need to be aware of this time commitment. And it's just with the current funding landscapes and the, how do I say this? It's just, it needs some evidence behind it to show how long this takes. And we're writing up all of this stuff as a paper to just demonstrate like the immense amount of work it takes. And again, I'm not the first person to say this, but I do feel like it's not really appreciated how much resources are going into just data collection of 25 participants. Then again, digital methods do not work, surprisingly. So yeah, we've got an e-consent where we ask people to fill in, the study or the consent to participate in our study. So the e-consent option almost never works. There needs to be time set aside to go through the participant information sheet with people as well. It's the other thing. Sometimes we spend half an hour explaining the study participant information sheet. One of Huma's reflections, I loved the weather and time of the year. She said, like, don't ever try and recruit in December and January. People are hiding at home. And so interesting reflection there. Then what I found is that no single strategy or setting was more or less successful for recruitment at the moment. That's what we found. I'm sure there's evidence somewhere that says you should be doing one of these things more or less, but we've went out to so many different organizations and have done so many different things, and all of it is, as I said before, we're spreading ourselves thin and then get participants from each individual sort of organization we visited or event that we visited. It's never been one big event. And then, sorry, more lessons learned. I'll brush through this. Again, this is more for sort of researcher facing. So, you know, what we learned, we should be careful of when we do our grant application, when we budget, when we set up the study. So I won't bore you with this, but thank you all for listening to my ramblings and my reflection